I'm going to present today Davide emergencies, the real case scenario, what I've encountered in daily life. Case one, 28-year-old male known to have the Taiwan diabetes, diagnosed 8 years ago at his age of 20. Patient complained of vomiting, feeling unwell for a day, abdominal pain, vomiting on coffee ground, vomiting color vomiters. He used to have the poorly controlled diabetes. He denied anything apart from above mentioned. Unfortunately, he has a recent bereavement of loss of his dad 1 month ago that makes him feeling down. Examination wise, unremarkable except from slightly dehydrated and retching in front of us with actively nauseating and vomiting. But apart from that, he is on low air and hemodynamically stable. He is alert. Investigation wise, he has a OGD in 2020 with esophagitis. Infection markers are unremarkable, so as the others, except glucose 15, not really so high, but obviously ketone 7 with severely metabolic acidosis of pH 7.0, less than 7.3, with bicarbonate of less than 15. His bicarb was 7.5 with base excess of almost 20. Normal base excess -2 to +2 in the mathematics along the x-axis. The more to the left, the more acidosis. The more to the right, the more alkalotic. Severely acidotic. -20 10 times to the left from the -2. pH obviously 7.10, less than 7.2, almost fatal, except DKA. Obviously, this is not respiratory acidosis, showing that carbon dioxide is normal, washed out by acidotic breathing. Low carbon dioxide, 2.62. This is small breathing. Bicarbonate very low, 6.2. Normal range 18. DKA criteria less than 15. Base excess so to the left, -21. Normal is -2. Deviated -19 to the left to set as acidosis. High sugar or 21 on the top of that metabolic lactic acidosis of 2.5. Ketone was 7. So diagnosis of DKA was made. Fulfill all three criteria. Blood ketone 7, glucose more than 1133, and venous pH or less than 0.3. His was 7.0. Bicarbonate less than 15. His was 6. Not only the diagnosis, all the issues we need to fix. Hematemesis, background of the severe esophagitis on latest OGD, vomited around coffee ground, 500 ml in total. Being on rivaroxaban, no way for the deep vein thrombosis. He has known DKA with a background of poorly controlled DM, depression with recent bereavement. Management, admit to the higher level care, complex and coronary care units. We need to know the INR because bleeding on rivaroxaban, fixed rate intravenous insulin infusion. I will talk about this later. Continue with the long-acting insulin. Please bear in mind that we don't need to stop long-acting insulin alongside with intravenous insulin infusion. Of course, we have to stop short-acting insulin while on intravenous insulin infusion. Bleeding, anticoagulation need to be stopped. Rivaroxaban and the alendronic acid, which can cause a severe esophagitis, need to be stopped. Hong Kong Protocol, continuous infusion of the proton pen inhibitor S omeprazole 8 milligram per hour for 3 days to block the gastrointestinal round the clock, 24 by 7, to relieve gastric bleeding. We need to refer for the urgent OGD, after stabilization, antiemetics. So this is the real scenario cut we use in patient with diabetic ketoacidosis. Everything inside: glucose, ketone, acid level, pH, bicarbonate, etc. All the parameters, blood pressure, heart rate, etc. Oxygen. You need to fill up. So in terms of management, fixed rate intravenous insulin infusion. Why we call fixed rate? It need to be fixed regardless of the blood glucose level until acidosis resolved in terms of pH or bicarbonate, until ketosis resolved. Regardless of the sugar level, we are not going to change the rate of insulin infusion according to body weight. It's very simple. 60 kg man, 6 units per hour. 90 kg man, 9 units per hour of insulin infusion. Maximum 15 units per hour can be given, regardless of the sugar level. I will talk about this later. What is going to happen if the glucose less than 14? I will come back to this later. Not only the insulin, fluid resuscitation is very important. Aggressive IV fluid resuscitation initially with normal saline without containing the potassium containing fluid. 1 liter in 1 hour. Second, 1 liter in 2 hours. Third, 1 liter in 2 hours. Fourth, 1 liter in 2 hours. So on and so forth. Yes, you just follow the guideline. But please bear in mind that except from the first liter in 1 hour, the subsequent fluid need to contain potassium. It depends on the how the level of the potassium is. This is a real protocol sheet that we are going to use every day. You can see that the top first section was written in red. There's a first fluid, normal saline without potassium, need to be given in 1 hour. Second and third onwards need something containing potassium. Please bear in mind that we cannot give 10 millimole of potassium in an hour. We cannot faster than that. It's lethal. How about potassium in the fluid? This is a guide. No potassium if the potassium above 505. If potassium less than 3.5, you need to discuss ICU team whether quick potassium infusion is required with central line access in the intensive or the high intensity unit, where the VDVF arrest can be dealt with immediate resuscitation. Apart from that 3.5 to 5.5, you can choose either 20 millimole or 40 millimole potassium in the normal saline bag. Bear in mind that you cannot give faster than 10 millimole in an hour. So that means that 30 millimole potassium containing bag need to be given at least 2 hours. 40 millimole potassium containing bag need to be given at least 4 hours. What are we going to do when the glucose drop less than 14? Are we going to change the insulin? No. Insulin is not going to change regardless of the glucose level. That's why we call it fixed rate insulin infusion. Okay? How are we going to deal with this glucose drop without changing the insulin? So you need to give extra glucose. Or so that's very important. So when the glucose go down below less than 14, you need to give additional 10% glucose. 1 liter over 8 hours, that's equivalent to 125 ml per hour. Please be reminded we don't need to change insulin infusion rate until the patient out of ketosis, until the patient out of acidosis, regardless of the sugar level. But we need to support glucose if less than 14 with glucose containing infusion. There's a QR chart which will guide you how we are going to give glucose if the glucose is less than 14 or how we are going to give if the potassium. Are we going to use sodium bicarbonate? I would say no. Usually, no. Usually in DKA, we won't use that sodium bicarbonate unless severe DKA not responding to treatment over the 4 hour aggressive resuscitation. But that need multidisciplinary decision, including the intensive care physicians. Who and where are they going to be cared? Ketones, if more than six, this is the case. His ketone had was 7. My cup less than 5, pH less than 7.1, his pH was 7.0. Hypokalemia, pH would be less than 3, I would say. These are the conditions. Cardiac arrest can happen at any time with VD and VF, where the immediate resuscitation is required. Sometimes we need to fix airway. When the GCS is less than 12, they are not able to maintain the airway. Risk for aspiration, hypoxic, hypotensive, tachycardia, or bradycardia. Those need to be care in a higher level care, either high dependency unit or intensive care units. And I will get greater than 16. I'm not always calculating iron get. I used to see as a base excess. Normal, -2 to +2, don't forget. The more shift to the left, more acidotic. Serious complication can occur in DKA at any time because of rapid fluid shift, cerebral edema, pulmonary edema, non-cardiogenic pulmonary edema, or ARDS, hypo or hyperkalemia, even hypoglycemia. You may consider aggressive urine output monitoring, airway protection, may need a nasogastric tube insuction. If the risk of aspiration, you may need to deflate the stomach, but you don't need in all cases in extreme. You may consider antibiotics if you suspect infection. Prophylaxis of the venous thromboembolism is crucial because this highly thromboembolic stage. You need to rule out the myocardial infarction as a trigger, especially in the high-risk patient, like elderly who may have silent myocardial infarction. Troponin and ECG, but never ever do someone who you are not suspecting that. Thank you.